Hello there, it's Dimitri Vasin, and I'm a nephrologist in private practice in Seattle, Washington. I would like to share with you a case of unusual presentation of ADPKD-1 patient. In the next slide, you see the presentation. It was a 59-year-old female who I was called about from the hospital, from the resident in the hospital, who told me that he would like me to have a patient follow-up on a lady who is admitted with pyelonephritis, gross hematuria, and renal cysts with calcifications. And presentation was so confusing that I just kind of gave up at this point and said, okay, I'll see patient without patient. And when she came up, here's what I was presented with when I looked at the hospital medical records. Number one, yes, she was admitted to the hospital with left flank pain, gross hematuria, which she describes as V8 juice. Her serum creatinine was 1.18 with GFR 47. She has a history of mechanical mitral valve, and she had a suboptimal INR at the time of her presentation. It was 1.8. She had no fever and no dysuria. She had normal WBC count, and she had negative urine culture. Yet she was diagnosed with a pyelonephritis by radiologist, polycystic kidneys, and parenchymal calcifications. So she was sent to me for outpatient follow-up. So when I put her CAT scan on my screen, and then you see the photo of that on the right, indeed she had cysts in the kidneys. Indeed she had some parenchymal calcifications. Some of them could have been associated with a cyst, but hard to say. And she had in the left kidney wedge-shaped area of inflammation, or looking at her history and presentation, it was pretty obvious that this was renal infarct. Kidney contours were not particularly disfigured, and the kidneys were not enlarged. So I was puzzled whether she does have polycystic kidney disease or not. So I took her family history, and her mother is still alive at age 80, no evidence of polycystic kidney disease. Father died at age 59 from cancer with no evidence of polycystic kidneys. She has 3 siblings, 49 to 62 years of age, and 3 kids, 35 to 43, with no evidence of disease. But she does have parental aunt on her father's side who does have polycystic kidney disease, presumed autosomal. So diagnostic considerations at this point were hematuria, which I think was relatively easy to explain as an embolic infarct. She has no family history of ADPKD. She has multiple cysts with a relatively preserved renal architecture. She has nearly normal renal function for typical ADPKD-1 patient, and she has multiple parental calcifications. So I could not really put all of these things together clearly enough to make a certain diagnosis. And at that point, I thought about ordering a Rhinocide test to clarify whether she has some alternative explanation for renal cystic disease and calcifications, one of the syndromes, or just combination of the 2 different abnormalities. So test came back positive for PKD1 gene, autosomal dominant, with a particular variant. Will not dare to read you what it is. It's on the screen, and it is obviously likely pathogenic. So in this case, benefits of Renasight test is that first it confirmed diagnosis of ADPKD-1 in this patient, which clarified and also clarified the reason for somewhat atypical presentation. This particular variant, this particular mutation, is a so-called non-truncating mutation that is associated with about 10 years later onset of end-stage renal disease in patients who are affected, even though it does affect ADPKD-1 gene. So that made sense. Also, once you diagnose the patient with ADPKD-1, and obviously if there is any history of suspicious death in the family, you would screen them for cerebral aneurysms. In this case, that was not the case, and that was not needed. We ruled out other multiple genetic causes for renal cysts, hematuria, and parenchymal calcifications. So all these are three separate issues. It provided valuable genetic information for patients' siblings and offsprings, because now they don't need to wonder if they have renal cysts, whether they have a PKD or not, and they have already more or less mapped the scale of progression and onset of end-stage renal disease. And there's also changes management. Remember, she was also referred for follow-up for calcifications involving renal cysts. In ADPKD-1, those cysts are not at any more increased risk of developing renal cancers than in a regular population. So regular CT surveillance and radiation and obviously expense and inconvenience is spared for this patient. In conclusion, I think that was a very valuable test. I think I got great support from the Terra team that helped me to understand the mutation and its clinical implications, and both patient and myself were very satisfied with the service. Thank you again for listening to my presentation, and have a great day.